kılavuzların sonuçlarını veriyor. Her ikisi de klopidogrelde, ticagrelor'da kullanılabilir. Fakat kanama riski potansiyeli iskemik yara ağır basmadıkça ticagrelor'un klopidogrele tercih edilmesi daima önerilir diyor. Onun nedeni de tamamen plato çalışmasıyla ilgili. Burada yine özellikle yıkanma süreleriyle ilgili. Bu da 3 günde etki süresi çok hızlı bir şekilde pik yapıyor. Bıraktığınız zaman da 3 günde aşağı iniyor. Bu da onset offset çalışmasının sonucu. Bunların içinde aslında etki başlaması ve etki bitme süreleri en kısa olan ticagrelor onun slaytlarından bir tanesi. Şimdi geldiğimizde bu kılavuzun ST elevasyonlu bölgesi. ST elevasyonlu bölgesinde potent bir P2-12 inhibitörü, yüksek kanama riski gibi kontraindikasyonlar olmadığı sürece perkütan koroner girişim öncesi veya en geç perkütan koroner girişim anında aynı zamanda 12 ay boyunca önerilir. Hangileri? Prasugrel ve ticagrelor veya ticagrelor ikisi de öğrenir. Ama eğer perkütan koroner ticagrelor'u her koşulda kullanabiliyorsunuz. Prasugrel'de ise mutlaka hastaya perkütan koroner girişim yapılıp, daha doğrusu anjiyosu yapılıp ondan sonra kullanmanız öneriliyor. Her ikisi de klas 1 sınıfta karşınıza çıkıyor. Aspirin tabii bunların hepsinde, bütün çalışmalar aspirin artı, onu unutmayın. Bazen sahada görüyorum yani bunu vermişler ama hastanın aspirin yok. Öyle bir şey söz konusu değil. Yani bugün eğer aspirin bugün icat edilmiş olsaydı herhalde kutusunu 1000 liraya falan alamazdık yani. Öyle bir durum var, onu da unutmayalım. Bütün çalışmalar hep aspirine ek olarak veriliyor çünkü. Bu 2020'de ESC kılavuzu yayınlandı. O kılavuzda önce hani elimizde neler var? Elimizde hala bunlar var. Klopidogrel, prasugrel, ticagrelor. Buna cangrelor eklendi ama henüz Türkiye'de galiba ruhsatlanmadı. Fakat bir değişiklik yaptı 2020 kılavuzu. Dedi ki eskiden hani 60 kilogramın altında kullanılmazdı. Şimdi 5 miligram kullanmanız gerekiyor. 75 yaş üstü hastalarda da dikkatli kullanmanız ve yine 5 miligram kullanmanız gerekiyor diyor. Fakat elinizdeki prasugrel tabletlerinin 10 miligram olduğunu, çentikli olmadığını, bunu da kolay kırmanın çok mümkün olmadığını hatırlatmak gerekecek herhalde burada. Yani bunu biraz gevşetmişler prasugrel için. Onu bilmenizde fayda var. Eskisi gibi değil. Ticagrelor'da herhangi bir değişme yok. Aynı dozda, aynı şekilde sistemdeki yerini koruyor. Bu da non-ST elevation MI'lardaki kılavuzun parçası. İşte burada bir değişiklik yapılmış. Buradaki değişiklik eskileri aynı. Yani tercihler aynı. Fakat perkütan koroner girişim planlanan non-ST elevation akut koroner sendrom hastalarında prasugrelin ticagrelor'a tercih edilmesi düşünülmelidir. Şimdi bu eklenmiş. Daha önce burada böyle bir uyarı yoktu. Bunu ekleyen şey aslında baktığınızda İSAR-REACT çalışması, İSAR-REACT 5 çalışması. Bu arada bu ikisinin 17 ile 20 arasında sonuçlanan İSAR-REACT 5 çalışması. Buna istinaden ekleniyor. Altını çizmek lazım. Bunu klas 2, sınıf 2A olarak öneriliyor. Yani sınıf 1 mutlak kullanmalısınız, etkinliği kesin gösterilmiş değil. Sınıf 2 etkinliğini gösteren çalışmalar var ve iyi düzeyde çalışmalar var. Ama 1 olacak seviyede değil demek istiyor. Aslında bu çalışmaya baktığımızda gerçekten bunun 2A mı olması daha doğruydu, 2B mi olması daha doğruydu? Bunu bir kritik etmek lazım. Biz etmemişiz zaten, herkes etmiş ama çalışmaya baktığınızda sadece 2 merkezli, Almanya'da ve İtalya'da yapılmış. Ağırlık hasta grubu Almanya'da. Açık etiketli, yani randomize kontrollü kör bir çalışma değil. Open label, açık etiketli bir çalışma. Tek bir açık etiketli çalışmanın ilk defa ben kılavuza bu kadar net girebildiğini gördüm. Benzer bir şeyi amiyadoronda gördük 2000 yılında restorasyon kılavuzuna. O da buna yakın bir, hatta bundan bir tık iyiydi o çalışma. Kılavuza girdi ve lidokain kullanmamaya başladık. Sizin teveletünüz yetenler var, yetmeyenler var içinizde. Ama uzun yıllar biz amiyodoronu kullandık. Sonra ne oldu? 2015'te ne oldu? Lidokain de kullansanız aynı dediler, amiyodoronla. Ama o arada dünyada lidokaini hatırlayan kimse kalmadı. Yani böyle çok kuvvetli olmayan çalışmaları bütün kılavuzun ortasına gömmek de her zaman biraz dikkat edilmesi gereken bir konu. İçine baktığınızda çünkü hastaların büyük bir %46'sı non-STEMI, %41'i STEMI, %12.7'si anstabil anjina. Hastaların %84'üne perkütan koroner girişim yapılmış. %2.1'i bypass'a gitmiş. Bunda MACE çalışma, yani ölüm, stroke vesaire MI takip ediyoruz ya. Bu 12 ay çalışıyoruz, takip ediyoruz. Bunları monitörler tek tek chartlardan, başvurulardan hastayı takip ediyor. Bunlar telefonla bakmışlar. Yani açmış, siz öldünüz mü, stroke geçirdiniz mi, MI geçirdiniz mi diye hastaya sorarak yapılmış. Ne kadar hastaların? %83'ü neredeyse. Şimdi böyle olunca non-estelation hastalarda randomizasyondan sonra ilaç yüklemesine kadar geçen süre ticagrelor grubunda 6 dakika. Yani hastaları randomize ediyorlar. 6 dakika sonra ticagrelor'u bir gruba verebiliyorlar. Prasugrel grubunda 61 dakika. Neden? Yani bir kere zaten anjiyo yapmaları gerekiyor. Yani anjiyo yapmadan onu veremedikleri için bir 60 dakikalık süre hasta bu tedaviden mahrum kalıyor. Bir yıllık takipte ticagrelor kullananların %15.2'si, prasugrel kullananların ise %12.5'i ilaç kullanımını bıraktı. Yani özellikle ticagrelor grubunda ilaç kullanımını bırakan sayısı biraz daha yüksek. Birazdan başka bir veri daha vereceğiz. Bakın, ticagrelor grubuna dahil edilen 2000 hastanın %98.7'si yükleme dozunu aldı. Bu hastaların %81'i ticagrelor ile taburcu edildi. Ama prasugrel grubuna dahil edilen hastaların %86.1'i şeyi alıyor, yükleme dozunu alıyor. %80'i sadece ilaçlarına devam ediyorlar. Yani bir grup hasta prasugrelle çalışmaya katıldığı halde %6'sına şey verilmiyor hastaların. Prasugrel verilmiyor çıkarken. Böyle olmasının ne önemi var? Çalışma kör olsa bir önemi yok. Ama açık etiketli olunca, yani bunu başlayanlar bunun hangi grupta olduğunu görebildiği için burada bias riski taşıdığını söylemek gayet normal. Eğer kör çalışma olsaydı bunun bir önemi olmayabilirdi. Evet, etkinlik analizinde onun sonuçlarında herhangi bir sıkıntı yok. Etkinlik analizinde burada prasugrelin ticagrelor'a üstünlüğü var. Elbette ki kılavuza girmesi gereken bir çalışma. Fakat klas 2A mı girmeliydi, klas 2B mi girmeliydi, o tartışılabilir. Ticagrelor'un yerini koruduğu kesin. Bir de bizim için şöyle bir durum var. Biz hastaları sıfır noktasında gördüğümüzde bu ürünümüzü başlamak istiyoruz. Fakat normalde aslına bakarsanız yani prasugreli bir kardiyolog anjiyografi yapmadan başlamaması gereken bir ilaç. Aldığı ruhsatın şekli ondan kaynaklanıyor. Böyle olunca şöyle baktığımızda açık etiketli olması, hasta sayısı az olması, randomizasyon grubunda ticagrelor grubunda 1.3, prasugrel grubunda 13.9 hiç ilaç başlanmamış. Belki de hastalara ilaç başlamamışlar çünkü kötü oldukları için, bilemeyiz yani. Kör olmadığı için, bunların hepsi açık etiketli olmasından dolayı soru işaretli. Biz böyle bir çalışmaya yollasak bunu çok daha farklı değerlendirirler, öyle söyleyeyim. Evet, eleştiri yapılacak çok şey var ama bunları zaten yazmışlar. Yani literatüre de yazmışlar. Buradaki değerlendirmenin bir etki olduğu kesin. Bunun üzerine gidilmeli ama bu düzeyde bir etki midir, klas 2A mıdır, biraz abartılı bir etki midir diye yayınlarda çıkmış. Elbette bu bir ticagrelor çalışması. Bunun mutlaka karşılığındaki çalışmalar da bu sorulara cevap veriyordur. Bence onları da dinlemenizde fayda var. Ben bu ayağın bu tarafını anlatıyorum. Ama özetlersek hızlı etki başlaması, primer sonlanım noktasında %2'ye varan mortalite azalması ve klopidogrele karşı mortalite azalması. Bakın az önce Türk-MI çalışmasında mı gördüm hatırlamıyorum ama onda gördüm. Türkiye'deki başvurularda %50 civarında şu anda hala klopidogrel kullanılıyor. %41 civarında yanlış hatırlamıyorsam ticagrelor kullanılıyor. %7-8 civarında prasugrel kullanılıyor. Bunun tek bir sebebi var aslında. Bu ilacı siz başladığınız için. Yani siz değil de kardiyologlar başlasa, yani bekleyin anjiyo yapalım öyle başlayalım deseler bu oranlar yüksek olur. Bu etki için kardiyologlarla beraber mutlaka çok hızlı karar verecek bir sistem kurulması lazım. Artık bunu kendi iradenizle yorumlamak da size kalan bir şey. Benim anlatmak istediklerim bu kadar. Sormak istediğiniz sorular varsa ya elimden geldiğince yanıtlamaya çalışabilirim. Sıkıldınız herhalde. Peki çok teşekkür ediyorum katılımınız için. Sağ olun.
So, good afternoon. We are starting now. It's a great pleasure to chairing this session with my colleague Anton Chamy. And we'll talk about the COVID situation. So, we will have 4 speakers, and the 2 speakers are in the room. The 2 others will be on Zoom. So, it will be a pleasure, and we'll start by Dr. Barbara Hogan. She's the past president of USIM, and she is a very close friend of me. And she will talk about the situation. And I know you are a German, so you will be on time. So I'm very concerned about that, about the new concept in emergency medicine. So please, Barbara.
Thank you very much, Eric and Mr. Chairman. First of all, I would really like to thank Professor Bazakanda and Professor Bechet Al for the kind invitation here to your wonderful Congress. As well, I would like to thank the organization committee with Emre Tektik and his team. So thank you very much indeed for this. I have the pleasure to tell you something about the future strategy for Europe after COVID and more outpatient care to replace hospital inpatients. And this, of course, will be a challenge for EDs and new types of medical treatment centers. In my view, emergency medicine in Europe has gone through 5 phases of development. And when we start with the phase 1, there were not a real strategy in emergency care. The second phase saw more professionalization, such as a specialty physician for emergency medicine and proper organization of emergency departments. And here is just one example of my department in Hamburg, Germany, and with 60,000 patients a year. We have an efficient interdisciplinary work and high-performance teams as a reality. As in Germany, we don't have the specialty in emergency medicine. We have to really work interdisciplinary and multidisciplinary. In our ED, we have IT, intelligent IT solutions. We work with case management and workflow orientation. And we have a patient-focused organization like First View and Fast Track systems. So the emergency care phase 3 is, and now you will see I have now the CEO position in the hospital, so we are coming that the ED is no longer a cost center, coming to a profit center emergency department, to the interdisciplinary emergency department, to a division ED, hub ED in a big hospital group, for example, to corporate center of excellence emergency department. And this means coming just from budget control and administration to value net management. What means value net management for the emergency departments? If you are the head of the department in a hospital group, for example, there you are the head of probably 4 or more emergency departments, then every emergency department has to fill in the patients to the competence centers of the hospital group. And this means provision of coordinated hospital group network healthcare. And then the emergency departments as corporate center of excellence, really coming from cost center and profit center to competence center inside the networked healthcare holding. The international problem is ever more patients in emergency departments. And here we have a study from Jan Storwans in Belgium, 2017, about the growth of inappropriate use of the ED. And you can see with the blue thing that the non-ED patients are rising up. What is this here? We had another study in Hamburg, Germany, in 10 emergency departments, so that we have 20% of patients in the emergency departments were not in need of emergency care. The situation before COVID was huge numbers of ED patients, many of them misusing the EDs. COVID made big changes. In many countries, there were a very big fall in ED patient numbers, some up to 50%. And I have just some examples in Turkey, for example. In Turkey, the number of patients in some EDs fell by about 50% during Corona. And the question is, did this mean only serious emergency cases came during the lockdown? Or does this mean that in normal times, a lot of emergency patients are not emergencies? In Germany, we have the same picture. Germany has 40% less patients in emergency departments in 2020. And in England, for example, in April 2020, the first full month of lockdown, the number of ED visits was down more than 50% compared to the same month in 2019. Before COVID, we had a lot of studies focused on the core problem: how can we reduce the massive numbers of patients misusing the emergency departments? Were we wrong to think that it is not possible to stop the rising number of emergency patients? Are about 50% of the ED patients at normal times are not emergencies? Do we need a new emergency care concept to deal with this? A new emergency care concept must also be created considering the challenge of the big trend in healthcare reducing numbers of hospitals and hospital beds. And here you see a huge difference in the number of hospital beds in major countries. Germany, for example, has 8.3 hospital beds per 1,000 inhabitants. The hospital beds per capita have fallen in all the OECD countries, except Korea and Turkey, because Turkey seems to have a positive case increasing beds linked to a lower hospitalization rate. And the average length of stay in hospital has also fallen in most OECD countries, potentially indicating efficiency gains. So here you see the number of lengths of stay in days by the OECD. So the question is, if people in a country stay longer in hospital, does it mean they live longer? Life expectancy in a country is not correlated to the number of hospital beds or length of stay in the hospital bed. So the challenge for the emergency care concept phase 4 is not get the patient out of the hospital bed, but do not get a patient in a hospital bed. So using the emergency department as a strategic control instrument to increase or reduce the number of in-hospital patients, use the ED as an out-of-a-bed tool, or use the ED as a get-in-a-bed tool. And I will give you 2 examples, what we did in our hospital. We could use the ED as a strategic control instrument for get-in-a-bed. If a hospital needs patients, the ED can provide them. You all know about these that you cannot find the beds in the hospitals, but they are some. The line in the middle, you see, is the goal of the hospital in patient bed occupancy. The ED on the left massively overachieved. Most other departments underachieved, but they could have achieved if they accepted the ED patients. Here you can see that we have 150 sick in the ED for 1 month, and the others are a little better because they accepted the ED patients. The ED as a strategic control instrument for not in a hospital bed is much easier because we have this exit block everywhere. These graphics show a rising number of ED patients, and we have 38,000 in 2009 and currently about 60,000 emergency patients per year, but reduced the number transferred as inpatient to the hospital. So now we come to the emergency care phase 5, using new care centers with cross-sector boundaries. And I'm talking about the sector outpatient care and the sector inpatient care. But crossing sector boundaries need a transformation away from the silo hospital hierarchy, with their orientation on function plus their hierarchy working like operational islands. And we leave the silo mentality behind towards a process-oriented and patient-centered expert organizations. And what I mean is that outpatient clinic, treatment clinic, EDs, and hospital and aftercare are working together in an integrated healthcare to be a high-performance healthcare organization. And for this, we need some kind of hybrid outpatient clinics for treatment and diagnostics. And this could be like this. We have the treatment clinic, some kind of diagnostic center, where all the basis emergency care for all outpatients are coming. We have specialists there, using by these treatment clinic and using by the hospital. And we have a joint clinical decision unit award for daytime observation of patients, and this could be used by the hospital, by the emergency department. And if patients from the clinical decision unit necessarily have to go to hospital, then they can immediately go there. So at my new clinic in Hamburg, I'm just building such a hybrid thing with general practitioner and specialist physician care, and we're starting this new hybrid emergency care, and we started already in 2019, and just with 6,000 emergency and acute patients, and only 7% transferred to the hospital. As well, we make consultation with telemedicine, live stream for homes for the elderly, that they are not coming for everything and anything to the emergency department. And this means big time savings for ambulances and doctors. This is a new photo of our Elbe Medical Care Center as a regional care campus, and of course it's already published. The next generation of emergency care, and we talked this morning about artificial intelligence, many new possibilities are being developed with digital technology. For example, in Germany, we have a Medibus railway to fill gaps in the healthcare network in rural areas. We have Henry the dentist. This is a clinic on wheels, a mobile dentist practices. And we have a self-driving medical clinic on demand, which patient can get consulted and diagnosed by video link, get a prescription, or transported to an ED. Visits could be ordered with a mobile app. And in China already, we have the artificial intelligence-powered unstaffed one-minute clinics in public areas, provide a range of smart medical examination devices, and provide users with one-stop medical and healthcare services, including consultation and medicine. Thank you very much, and teşekkür.
Thank you, Barbara, for this excellent presentation. Do we have any question? Yes, please. Chat.
talk about the new concept of emergency medicine. Let us talk for the future, further concepts. One day, if you become the Ministry of the Health in Germany, what do you want to change in the emergency department? Hopefully you will become.
Yeah, thank you for this question. Immediately implement the specialty in emergency medicine, because now in Germany we have in the emergency department 27 specialties around the clock every day. So we need just one, as you in Turkey. So we are very, very happy to invite you to the USEM Congress to Berlin next year to tell the Germans how to do it in Turkey, how to do it in France, how to do it in Spain, how to do it in Italy and wherever. So this is what I really would do. But the reduction of beds and the reduction of hospitals, even in countries which has so many beds per 1,000 inhabitants, like Germany and Korea and US, for example, they have really to reduce it, because the best countries are Turkey, are Sweden with 2.3 beds per 1,000 patients, 1,000 inhabitants.
No further question? Thank you, Barbara.
Okay, so we move on to our next presentation. For this one, I have the honor of presenting my colleague and senior in the profession, Dr. Eric Revue. He's head of the emergency department of Hôpital de la Riboisière à Paris, and he's co-chair of pre-hospital at USEM.
Hello, it's always an honor, a pleasure to be with you. And we talk a long time, we have a lot of papers about the COVID. So I won't put anyone, no papers, no statistic about the COVID. But just talk about the problem we had with that. I don't have any conflicts to declare. Imagine the COVID-19. But not this one. COVID 1999. It happened. It was the Spanish flu. A lot of patients, people were wearing masks, a lot of patients in the department, and the disease is exactly the same, with hundreds of patients who die. What's the main difference? No TV, no internet, no iPhone, no social media. With the same pandemic, they have to face the same disease, but there's nothing at all that's the problem. Historical, from before 1919 to now, we always had to face with the anti-vaccine people. People that don't trust vaccine for many years. At the beginning, for Jenner to Pasteur, it was really our problem. Why that? Because we just understand a few decades before, that's the mechanism of the vaccination. We didn't know how it works really. So it's hard to explain to the population that need to have the vaccine. It's not a natural, the vaccine. Vaccination for people, for kids, you'd have to explain to babies, to the family that they need to use that. And we always have criticism about the anti-science force. A lot of people everywhere, since the beginning of the vaccination, were against the government, it was politics, against doctors. Maybe you have to know that even Jenner or Pasteur, he had to face because all the population said, maybe you want to put the vaccine because you want to make money with that. So it's the same that happened before. The problem here, regarding to the WHO, doubts about vaccine is one of the top 10 threats that we have in this year. It's because we have a lot of things now. We have made a lot of progress. We are facing. It's still the main problem that we have. And we have the main challenge. We have to vaccine a lot of people. And 60 million of elderly patients are on high risk to be vaccinated. So we have many problem solving. It's a funny joke. There's a different way. You've got a problem, you have the German, he will fix the problem. No problem. You find a solution very quickly. I don't make a comment about the US. They put in a bomb, they can put in a jail, they solve the problem. In Russia, you have seen how they can fix the problem. I think the worst could be the French. You have the problem, you are fighting, we are always on strike. The problem is we have more problems later. So it's really hard to have that. So tell to a French, you know what, you need to wear a mask. And he says, I don't want a mask, I don't want a mask, I don't want to. It's my freedom, I don't want to. Okay. Maybe we can tell him, you know what, the Germans, the Turkish, the English, they have masks, but you, the French, you don't deserve it. And the French will come and say, okay, that's not normal. I want a mask, me too. I want to wear a mask now. So that's very, very complex to explain to the people that it could be demographic, structural, social, or behavior problem to vaccinate people. There's another thing we are facing. Anti-vaccine is not vaccine hesitancy. We have people that will refuse everything. They don't want the vaccine. You can say anything, they won't have it. And you have some people, maybe they're quite hesitant, that don't trust. If you explain, maybe they will change. Maybe they will have the argument to explain that they could accept the vaccination. It's not hesitancy, it's not activism. We are facing people, they don't trust us. You can do anything, they don't trust us. Our role is to explain to people who trust us that we need to have a vaccine, and vaccination is good to prevent this disease. There are so many determinants for acceptance or refusal of a vaccine. Social, risk perception of disease. I'm safe, I'm healthy. A young guy say, I'm healthy. I don't have any comorbidities. Why do I have to get the vaccine? I don't need to. So mainly the thing we have to explain. It's unsafe. Is it safe? No. We have people that are looking on the media, and even doctors, they say, no, vaccine is not safe. So they need to trust that, and we have to understand here are the main problem we're facing. Politics, yes, it's a big problem because it's very close when you have a campaign with politics. Politicians have a very big role. We don't have any comments about Trump, but we know how he fixed the problem. He didn't, anyway. And it's really a problem that had in